Yeah, ma'am, you can.
Please go ahead, Lesh. You can start.
Good morning, everyone. Today I am speaking on the management of a very, very important disease and very common. So, stroke, let's start with it. So, this is how I will go about it. Let us know what is stroke, the types, what is the burden of the stroke, relevance of cerebral circulation, and how we are able to gauge clinical features based on that, differential diagnosis, and pre-hospital diagnosis based on stroke scales, pathophysiology, understanding why we are doing whatever we are doing, the management starting from pre-hospital. So each and every step of the management is very important. And once the patient comes in emergency, what are the timelines you have to stick to? The ABC, history, physical examination, labs, radiology, and reperfusion, the most important part, about thrombolysis, what are our goals? How much time do we have? Which drug we should use? Which patient? How should we select our patient? What are the prerequisites before we thrombolize? How we will monitor? What will be the side effects that we can expect, and how to deal with that? Then we will discuss about mechanical thrombectomy, the other aspects like antiplatelets, anticoagulants, and statins, and other aspects of the comprehensive care of a stroke patient, and then we can summarize. So I'll start about, just the stroke. It is an acute neurological emergency, and it is a pure vascular phenomenon which results from partial or complete shortage of blood supply. So it could be either because of obstruction of the blood vessels, which is ischemic stroke. So today we are discussing exclusively about ischemic stroke, or it is also because of the leakage of the blood and subsequently the brain is hyperperfused. So stroke is a clinical diagnosis and it is a sudden onset of focal neurological deficit of, of purely vascular origin. Of all the strokes, ischemic stroke is the most common and it is most rewarding to treat. And other types of stroke, they are less common, intracranial hemorrhages or because of subarachnoid hemorrhage. So the stroke, the global burden of the stroke is very high. Approximately 1 in 4 patients will have a stroke in lifetime. This is the data by World Stroke Organization. And it is also the leading cause of disability. And it is the second leading cause of death. And it is a third leading cause of death and disability combined. It also leads to many comorbidities like dementia and depression. And also the recurrence rate of stroke is also quite high after the first episode of stroke. And also the statistics show that the death rate because of stroke is increasing. So why stroke is important? Because stroke it leads to permanent loss of function. It affects the quality of life of the patient. So his ability to walk, speak, eat, grasp, ability to have an independent living, to earn. So, and also it leads to a lot of social isolation, depression, dementia. So that is why the benefit or the gratification of treating stroke is really very high, and it is one of the most time sensitive diseases in the health. So what are the risk factors? We all know. We can skip it. But then etiology is important. So most of the strokes are thromboembolic in origin. So, and the most common location of the atherosclerotic plaque is in the internal carotid artery, just after its bifurcation from the common carotid artery. And in Asian patients, there is a higher incidence of intracranial atherosclerosis versus the whites. So what is the implication is that such patients, they have higher reocclusion rates after thrombectomy, and there is increased requirement for stenting and also the need for antiplatelets. So they have a higher chances of hemorrhagic complications after mechanical thrombectomy. So arterial causes are the most common causes. Then there are basically embolic is the most common type. It could come from the major vessels or from the heart. So there are other hematological causes, like which are rare, but still they should be considered. So approaching etiology of the stroke is will help us in preventing the long-term prevention and the other aspects of the stroke. So clinically, it is an acute onset of focal neurological symptoms and signs which are confined to a particular vascular territory. And these compared to TIA, there is a persistent neurological deficit. So once we are aware about the vascular territories, which regions they supply their clinical feature, we can apply this knowledge in localization of the lesions clinically and interpreting the brain imaging and understanding what functional deficit, what complications patient will have, prognostication of the patient, and also understanding the mechanism of stroke in the patient. So this will help us. So this is just an example how a posterior circulation stroke, we can correlate the imaging findings with the clinical picture which comes into, which we have at the bedside. So like if there is occlusion of the posterior cerebral artery, so this supplies the temporal cortical and parietal cortical areas, which could lead to memory deficits, alexia. The involvement of the thalamus can lead to sensory loss and disturbances. Involvement of the occipital lobes can lead to visual field defects. And also involvement of the brain stem, it could lead to cranial nerve palsies and classic locked-in syndrome. The involvement of the cerebellum, because of the cerebellar arteries, it could lead to vertigo, ataxia, nystagmus, and other cerebellar signs. So what is the pathophysiology of the stroke? It is important to understand it is not only a neuronal death or neuronal ischemia which matters. Now the advances in the stroke, there are at various levels. At the cellular and molecular levels have understood they have recognized the importance of the neurovascular unit as a whole, which includes the microglia, the pericytes, the astrocytes, and the extracellular matrix. So all of them, they play a role in the molecular and cellular events, ischemic events, which ultimately lead to manifestations. Like they will affect the cerebral blood flow regulation, blood-brain barrier permeability, the inflow of the immune cells, the neurotrophic functions, and clearance pathways. So this is at the cellular levels when these are the mechanisms, these are the 5 basic mechanisms of the stroke: excitotoxicity, increased production of the reactive oxygen species. There is neuroinflammation, cortical spreading depolarization, necrosis, necroptosis, and autophagy. So why this is important is this is one of the area where the research is also working, apart from thrombolysis, for cerebral protection strategies, for drugs which can target these pathways so that the brain has some time before irreversible damage happens. So this is the various way. Basically, there is glutamate excess of calcium. There is lot of anoxic depolarizations. Ultimately, this affects the energy balance. The brain, which is already compromised, doesn't have much time for the final infarction to develop, because the energy balance between the requirement and the energy needs, that is all affected by these anoxic depolarizations. And also inflammation, cerebral edema, the white matter loss. So all these things. So there are multiple things happening in multiple cells around in the brain area which is affected. It is not only the neuronal loss which leads to the final outcome. So coming on to the our understanding. So the first everything about stroke, the modern management of stroke revolves around the basic development of a concept about ischemic penumbra. So how this was discovered in animal models of cerebral ischemia. So it could be the ischemia, it could be focal, which is seen in our stroke patients, which is usually one of the blood vessels. It is partially or completely occluded. And in such patients, the blood flow is maintained by the collateral circulation by the other arteries, the circle of Willis, and by the small collaterals. So what is the difference is that, so in cases of focal ischemia versus global ischemia, in which there is complete cutoff of the blood supply to the entire brain. So there is no possibility, and the brain will, the areas, they will die rapidly. So in such cases, the focal ischemic cases, we have some time in saving the partially damaged areas versus the completely infarcted areas. So once the models of stroke, the focal ischemic models were studied, so we found that there is variation in the blood flow, cerebral blood flow in the regions which are affected. So it is not that the blood flow is completely, there is a gradient of decrease in blood flow. So this was the first major understanding. So in the core, there is totally absent or blood flow. In penumbra, the blood flow is less. In healthy tissue, it is normal. So also Astrup, he was instrumental in studying these blood flow thresholds, and he compared this blood flow threshold with the electrical activity of these regions. So he was the first who coined the term penumbra. So penumbra basically means a region which is between the almost dead and the normal region. So it gets its name from the solar eclipse. So this is the penumbra in which this is completely dead and this is a normal region. So this was a major scientific discovery, and the saving of this penumbral region, this is the foundation of all the interventions and all the imaging modalities that we are using in to save these stroke patients. So all neuroimaging is directed in estimating this penumbra, how much penumbra is left, even if the patient has come out of the conventional time windows. And all the vascular interventions are directed towards this, as well as the cellular interventions. So if we want to understand, so this is a normal region in which the cerebral blood flow is normal, which is 50 to 60 ml. And this maintains a normal autoregulation. And even if the blood flow declines, the cerebral perfusion pressure is maintained because of the change in the vessel wall diameter, which is the hemodynamic reserve. So then if the cerebral blood flow declines further, this leads to a region of oligemia. Oligemia means that the cerebral blood flow has declined, but the oxygen delivery to the tissues is maintained because the oxygen extraction has increased. So this area is functionally normal and as well as structurally normal. It does not lead to any neurological deficit, and it is also not the target for our therapy. So main target is this, in which the further decline in cerebral blood flow has led to decrease in oxygen delivery to the tissues, because now the oxygen extraction has reached a plateau. So now this region will become non-functional, but it is surviving. It is not dead, it is hibernating. It is structurally intact. So this is our therapeutic as well as the diagnostic target. And when the blood flow declines in the core, so the blood flow has declined below the threshold for structural integrity, the ion pumps have failed, and there is unregulated glutamate release and cell death has happened. So whatever we can do is to save this area. So what we understand is that this penumbra, although it is a stunned and hibernating tissue, but it is destined for infarction if we don't save it. That is the one thing. So it will not recover on its own versus oligemia. The benign oligemia, even if we do not, if there's an area of the benign oligemia, even if there is no reperfusion, it will survive. So we have to save the penumbra in order to improve the functional deficit. So this was a famous paper which quantified actually how much neurons are lost per minute if the stroke is untreated. So 1.9 million neurons are lost. So what we understand is that acute ischemic stroke is a dynamic process. It is not a one-time process of infarction. And this infarct grows quickly, but there is enough variance which has been observed among patients, how quickly the penumbra will turn into the core. So it can persist for long periods of time, up to 48 hours and even after several days. So patients, they were found to be fast progressors or slow progressors. So fast progressors, they had large core volumes, despite even if they presented early within the appropriate time period. But slow progressors, they maintained a small core volume and they maintained their penumbra. So what determines this progression? So there is basically four factors which affect the pace of infarction. That is the time and the hemodynamic factors, the tissue factors, and how quickly we have instituted the reperfusion therapies. So see, this is the scans of two patients. One patient who had a diffusion weighted imaging at 30 minutes, and after 150 minutes, So nearly right hemisphere has completely infarcted. In this patient, so there is this baseline loss of baseline infarction, and even after 4 hours, this infarcted area has remained the same. And this is the penumbral imaging. The penumbra was viable even after 4 hours. So that means in this in patient within 30 minutes she progressed to infarction, whereas this patient survived for 4 hours. The ischemia is still not irreversible. So time is not the exclusive factor which will determine the fate of the penumbra. So what are the other factors? So how is time important? So time, because ischemia progressing to infarction will depend upon how severe the ischemia is and how long the ischemia is. So time factor will give us in estimation of the duration of ischemia. So how long the patient has this area has been ischemic. So, but there is no particular threshold of time for. So there is no absolute time window for tissue viability. So every patient has its own time. So this is seen from this. So the rate of neuronal loss was very variable. This was a median rate of neuronal loss. So every patient is individual. So although time matters, but it is not the only thing. So then, so what are the hemodynamic factors? Because stroke is all about cerebral hemodynamics. So the how much is the collateral blood supply, which is the most important deciding factor about how long the penumbra will survive. The local perfusion pressure, myogenic tone, the blood pressure, the head position, age, gender, genetics, all these things affect the cerebral circulation. The tissue factors, how much is the tolerance of the tissue to ischemia? What is the local metabolic milieu, temperature, cerebral edema, has it set in? How are the peri-infarct depolarizations, any acquired comorbidities which are affecting the tissue recovery, and reperfusion strategies, whether you have instituted, was there a time for pharmacological reperfusion like thrombolysis, mechanical thrombectomy, or the spontaneous endogenous recanalization of the vessels. So from the theoretical concept to reality, the penumbra, it means a functionally impaired but viable tissues with undetermined fate. That is at a risk of infarction if it is not salvaged. It is contributing to the clinical deficit, and its resolution is associated with proportional recovery of the neurological function. So after this understanding, now we are moving from time window to tissue window or viability window approach, so that there should be a therapeutic window which is tailored to each patient's unique pathophysiology. So coming on to the management after understanding this basic aspect. So before I go on to the management, what I want to know, because all the time we will be assessing about the modified Rankin scale. So this is a functional scale. In all the studies, we are evaluating what is the improvement in functional ability of the stroke patients if we are instituting any treatment. So usually we aim for MRS 0 to 1, which is non-significant disability, in which the patient is able to carry out its usual activities without much disability. So then, so there are AHA guidelines about how we'll go about stroke. So there are 8 domains. Our arena is basically how, after the development of stroke, how we are able to deal it in the pre-hospital setting, in the hospital, how stroke treatment is done, the secondary prevention of the stroke, and ultimately the rehabilitation of the stroke. So this is basically the 4 areas, the 4 domains which will help. So in the pre-hospital setting, once the symptoms have occurred, there is sudden loss of focal brain function. So the use of by EMS is sent to the patient. So the use of stroke recognition scales, that has improved that will help in recognizing the stroke early. And also, not only the EMS can recognize a stroke, but also certain scales are developed which will help them to recognize that this patient has the possibility of large vessel occlusion. Also, the stroke protocol, use of stroke protocol by the EMS personnel, and optimal triage. So they should individualize the patient routing. What is the sending the right patient to the right center, and also pre-notification of the hospital. Stroke alert should be done even before they reach the hospital, so that the emergency department and the stroke team is ready to deal with this patient. So another major thing which is in the use of mobile stroke units. So there is a lot of research happening, and this is a growing thing, which I will discuss later. So the stroke recognition scale. So there are various stroke recognition scales. The main aim is they are quick screening tools which will allow the uniformity in assessment of the stroke deficits that can clarify the communication of the patient's status to the ED. So they will help it. They will be able to. There is diagnose the stroke. They are able to better communicate, and also they are able to identify the probability of large vessel occlusion and probably shifting the patient to a mechanical thrombectomy capable center. So there are few scales which are specifically useful for identifying large vessel occlusion. These are the scales. So basically, the scales which incorporate the cortical signs like hemi-neglect, they show better accuracy in predicting the large vessel occlusion. So once the EMS, there are two models basically. Once they have recognized a stroke patient, so there are two models. Either if they can shift the patient to the nearest center where the patient can be thrombolized, and then the patient, if has a large vessel occlusion, can be shifted to the thrombectomy capable center. So this is drip and ship model, or patient is directly transferred to a center where both of these are available. So although these models are compared, but there is no particular difference in the outcomes when these models were compared. So now the AHA recommends, so if you are able to reach this comprehensive center where both things can be offered, in less than 15 minutes, you can shift the patient directly to this center. Otherwise, go to the primary stroke center first and then to the comprehensive center. So the mobile stroke units. So mobile stroke units, they have shown improvement in outcomes of the patient. Why? Because they are specialized ambulances which will be dispatched from the emergency, to a patient who is suspected of stroke. So they are equipped with healthcare personnel which are specialized in acute stroke care. So they are and also they have a small bore CT scanner. So these ambulances can do the CT scan of the patient there. So which will establish the diagnosis of the stroke. Also, the diagnosis of the large vessel occlusion is established, and the thrombolysis is given in the ambulance itself. And also in the ambulance itself, it is decided that this patient needs a thrombectomy. This patient can be shifted to a thrombectomy capable center. Also, some basic labs and basic medicines which are needed that are also available in this. So it was found that from alarm to thrombolysis time, it is much better. And 10 times the patients who were treated within 60 minutes, they were 10-fold higher. So this first 60 minutes, first hour is called the golden hour. So more patients, if they're treated early, more will be the better will be the outcome. Also, it will help in the pre-hospital triage of the patient. And the other thing is that in remote areas which do not have access to in-hospital stroke care, this also helps. So even now in India, we have the few centers, they have the mobile stroke units. But the major disadvantage is the finances. It is very costly affair. So actually, how much the cost will translate into the final outcome. So how much ultimately we gain from it, those studies are also in vain. But these are very costly ambulances. So these are the basically randomized control trials. All of them, they have shown the common outcome was, so there was greater thrombolysis rates were higher. There was no change in secondary intracranial hemorrhage. So this is a safe way. And the primary outcomes in terms of the MRS score, that was also better. So even so these mobile stroke units, when they were compared with the standard care of the patient, so they were more beneficial when with other aspects like aspirin versus the normal stroke care, the use of TPA within 3 to 4.5 hours. So they had better outcomes. And their outcome was, their benefit was nearly to that when the TPA was given within 3 hours of onset. And this paper, basically these investigators who are working with this, so they recommended that this should be the level of evidence for this particular thing should be upgraded to level 1A. So then once the patient has reached the emergency department, so there are certain timelines because time is very important, which we should stick to. So once the patient comes to the emergency, within 10 minutes, he should be evaluated by the emergency physician. Within 15 minutes, a specialist, the stroke team, neuroimaging should be done within 25 minutes, and within 45 minutes, the CTs or MRI should be evaluated, and within 60 minutes, which is the door to needle time, should be ideally less than 60 minutes. So the stroke team, what is the importance of stroke team? There should be an organized protocol for the evaluation of emergency, for the emergency evaluation of a stroke patient. And the stroke team should include the neurologist, neurointervention, neurosurgeon, the nurses, lab, radiology. So they should also, so the use of the designation of stroke team that has also lead to better outcomes. So once the patient reaches the emergency, the first and foremost is management of the area. So these patients are likely to have impaired consciousness and bulbar dysfunction, which could lead to loss of airway and aspiration. So they might require intubation, and also because of the raised ICP, the risk of vomiting, there is risk of hypoventilation. They can have carbon dioxide retention, which can adversely affect the outcome. So they may require ventilation. And also they could be volume depleted, especially in elderly patients. They have seen that they are usually volume depleted, which can affect the cerebral blood flow. So you should appropriate volume resuscitation. Ideally, it should be, we have to avoid the hypotonic and dextrose containing fluids. And this fluid should be individualized according to the electrolyte and cardiovascular status of the patient. So after you have ensured the ABC and the important questions in managing and assessing this patient is, number one is whether my patient is having stroke. What if yes, then what is the type of stroke? What is the time of onset? And is he a candidate for reperfusion? These are the basic questions in which you should, once a suspicion of stroke. So stroke mimics, there are various stroke mimics, which you will have to rule out on the basis of history as well as on the basis of imaging and physical examination. So time of onset, what time of onset, why it is important? So there is basically two types. Either it is a witnessed stroke. So it is called known onset stroke, or it is an unwitnessed stroke in which nobody knew when the stroke happened. So this is called unknown onset stroke. So establishing the time of symptom onset is very important because of the narrow therapeutic window for reperfusion in such patients. So it is easy in case of a witness stroke, but in a non-witness stroke, so basically the question mark arises here if we do not know when the stroke happened. So there is one more term which is used as last known well time. So for unknown onset stroke, the symptom onset is defined as the time the patient was last known to be normal or at baseline neurological status. So there are two types of unknown onset stroke. So either the patient wakes up with stroke symptoms and they were not present before he fell to sleep. And usually the sleep duration is more than 4.5 hours, which is the therapeutic window. So in such patients, we can ask whether he got up in the night and at that time, was he normal or not? And what was their baseline health status when they got up? So the last known well time is a time at which they were last seen to be normal. At what time, whenever he slept, so that will be his last known well time. So usually wake-up stroke, it is found that these strokes, they are milder strokes. They're usually lacunar infarctions which occur because just prior to awakening. So usually they have a short onset and it occurs because of the platelet aggregation during sleep. Whereas unknown onset stroke, then it can be of two times. Either the patient has woken up with the during the after sleeping, so which has happened in the night time. The patient will wake up with the stroke, and this is called wake up onset stroke. Or if the stroke occurs during the daytime, it is unwitnessed, and the patient is unable to tell when exactly, how exactly the symptoms started because he's aphasic, he's confused, there is already dementia or something. We are not able to find out when the stroke happened. in the daytime. So this is called unknown onset stroke. Although wake-up stroke is a type of unknown onset stroke, but it is functionally it is a different type of stroke, and it should be both of these should be considered as separate entities. So the incidence of these stroke is 1 in 5 is wake-up onset stroke. And unknown onset stroke. In terms of severity, wake-up onset stroke, they are milder than the known onset strokes also, and unknown onset strokes also. And unknown onset stroke, whether it is ischemic or hemorrhagic, it is always more severe. It is associated with older age, female subgroup, atrial fibrillation, higher premorbid MRS scores. Usually these patients live alone, and their chances of chances of having an independent life is very less, and high in hospital mortality is observed. So there we should consider three stroke subtypes. Basically, one is known onset, in which there is an exact time when the symptoms happen, and these symptoms they were witnessed. Wake-up stroke, patient has slept and has woke up with stroke. Unknown onset stroke, stroke has happened during the daytime, but due to communication or other reasons, we are still not able to know exactly when the stroke happened. Of this unknown stroke, onset stroke is the most severe, most fatal, and most functionally disabling stroke. So when after you have established the time of onset, whether it is known, wake-up, or unknown, so the other part in history, this is why the history in such patients should be very rapid and very accurate. Our aim is to, number one, to know the time of onset, and to, on the basis of history, know the etiology of the stroke, whether the patient is having stroke, and to rule out all the contraindication that the patient may be having, because that could interfere with the thrombolysis. So you have to ask about, in terms of thrombolysis, history of recent trauma, surgery, if yes, what kind, whether there is any chance of drug abuse or overuse, there is a history of GI bleed, comorbid illness, which can affect the investigations or the other things, how you will evaluate this patient. What was the functional status of the patient before he had a stroke? This is very important, because most of the patients, they can have, they could be bedbound, they can have repeated strokes. Also, knowing what is the profession of the patient is very important in knowing whether this symptom which is having, it is leading to the disability in the patient or not. So drug history, knowing about antiplatelet, anticoagulants, anti-epileptic drugs, the social, smoking, alcohol, substance use, and the drug history. So this is, the history should be very focused and has some aim why we are asking this question. So vitals, the RBS, it is the only only lab investigation which is ideally needed. Neurological examination, it is also very important. And the scoring of the neurological deficit, NIHSS score, which will establish the severity of the stroke. Then checking the weight of the patient, because we have to give weight-based therapies. So examination, when you look at this patient, look for his GCS, facial asymmetry, whether there is loss of airway leading to stridor, shallow breathing, tongue bite, signs of trauma. So when we are talking to this patient, you should assess for aphasia and neglect. So touching, after you touch the patient, so assess for the symmetry of the pulses, whether it is asymmetrical, could be because of dissection, or it is irregular, suggestive of AF. Bruits are palpable or not. So listen for murmurs, stridor, and breath sounds. So all should be focused on the suspected. So this is the NIHSS score. Basically, the score is from 0 to 42. So it quantifies, why it is important is we are able to quantify the stroke, whether it is mild, moderate, and severity. There is no particular cutoff, but this is the usual cutoffs which are used. This facilitates communication. It is used to identify patients for fibrinolytic or mechanical interventions. It will allow objective assessment of the change in the clinical status of the patient, and it will identify those at higher risk for complications, which is intracranial hemorrhage. It will help in prognostication of the patient as it is correlated to outcomes, and that is why it is recommended for all patients on admission. So these are the components of the NIHSS score. So what labs? RBS is the only mandatory test which is needed. Coagulation, you have to send these investigations, but waiting for investigations to come and then starting the reperfusion therapy, this is not advised. Only time when we have to wait for this particular coagulation profile, platelet count and coagulation profile is when the patient is on a particular oral anticoagulant or low molecular heparin or antiplatelet, or there is history suggestive of thrombocytopenia, in which we are suggesting that there could be some abnormality. Otherwise, we should go ahead with the after checking RBS only. So after you have assessed the patient, the next step is imaging in the patient. So the goal of imaging is most important is to exclude the hemorrhagic stroke. And other part is in patients who are coming out of the conventional windows for reperfusion, identification of the penumbra by penumbral imaging, functional neuroimaging. Tissue clocking. Tissue clocking means that in wake-up strokes, using the diffusion-weighted flare mismatch, we are able to identify patients in which the stroke is less than 4 hours of duration. So identify the occlusion of the major extracranial or intracranial arteries. So we'll be able to know whether it's a candidate for thrombectomy. Extent of ischemic changes. If there is obvious ischemia, there's a large infarcted area, so it will affect the decisions for therapy. Identify the complications later on, cerebral edema or hemorrhagic conversion of the infarction. So in this way, we are able to select patients. So this is a prerequisite. Imaging is mandatory. So there is no clinical way to distinguish between ischemic and hemorrhagic stroke. So a plain CT head is sufficient in most patients, and they should be done within 20 minutes. And if you have time in the same setting, CT angio or MR angio can be done. But if there is a delay because in doing CT angio for thrombolysis, it should be done later on. So delay should not occur for neurovascular imaging if there are concerns about creatinine. So now this is the CT findings. Early changes in the CT scan. You can see a hyperdense MCA sign. There is loss of insular ribbon, loss of gray-white matter differentiation, loss of sulci. So these are the early ischemic changes which are seen in CT. And also the aspects, which is the Alberta Stroke Program early CT score. It is done to measure, it is a measure of early ischemic changes based on the CT scan. So Alberta scan basically for MCA strokes, so basically 10 points are given, 10 regions are given. So we take 2 cuts, one at the level of basal ganglia, one just below the basal ganglia, and 1 point is given to each. Caudate nucleus, lentiform nucleus, and the internal capsule. So 1 point is allotted to each for these subcortical structures. Then 4 points, and in this cut, 4 points are given to M1, M2, M3 each regions. And 3 points are given to M4, M5, M6 regions. So if there is hypodensity in any of these regions, so 1 point is subtracted. So if a patient with a normal CT scan will have a score of 10, lesser the score, higher the chances of higher ischemic damage. So this is the MCA territory aspect score. And this is the posterior circulation aspect score, in which 1 point is given for both right and left thalamus, cerebellar hemisphere, the thalamus, and posterior cerebral artery territory. And 2 lesions are given for midbrain and pons. So then the score is calculated out of 10. So this will help us in, again, assessing the patient, whether the patient we should include for reperfusion or not. So this is the perfusion imaging. Basically, perfusion imaging means that we are able to differentiate between core and the penumbra on the basis of the cerebral blood flow thresholds. It could be done either with CT scan or it could be done with MRI. So this is the CT scan imaging of the patient, in which the cerebral blood volume, it is normal, but there is a decrease in cerebral blood flow in the right MCA territory, and the mean transient time that is also delayed. So this is the penumbral region. This is the hypoperfused, hypofunctioning region, but it is not infarcted region. And in the MRI of the same patient, there is, in the diffusion weighted, there will be a hyperdensity in the diffusion weighted MRI. But in the perfusion weighted imaging of the MRI, there is a bigger area of hypoperfused area which correlates with the penumbra. So this is the penumbral region. So this patient has a salvageable penumbra, even if the patient has presented late. So this patient, on the other hand, had an MCA blockage here, and he had a diffusion weighted imaging of the stroke. It was done, and there was a diffusion deficit. Also, there was a similar perfusion deficit. So there was no mismatch in the diffusion weighted image and the perfusion weighted image. Basically, diffusion weighted image will tell you about the core, and the perfusion weighted image will tell you about core and infarct. The difference will tell you about the penumbral imaging. So because there was no difference, even if the patient came within 4.8 hours of stroke onset, so there was the patient didn't undergo any reperfusion imaging because there was no penumbra in this patient. So coming on to after we have imaged the patient and we have decided for thrombolysis. So this is the second most important reperfusion therapy. This is the second most important thing.
Shikha, can we
Yes.
just sorry to interrupt you here.
Yes.
We are at around 9 o'clock now.
Yes,
Can
sir.
we continue the treatment part next week? Is that okay?
Yeah, yes, sir. Definitely.
Is that okay with you?
Yes, sir, definitely. It's okay, sir.
Because I mean, you have covered it quite extensively. It's going on well. I don't want to kind of the treatment part, which again is a very, very important part, can give one more session to the instead of just rushing it.
Yes, sir. Yes, sir.
Srinivas, is that okay with you? Oh, I think Srinivas had to leave. Okay. So we will have the part 2 of the stroke with recent updates, which will cover mainly the the thrombolytic therapy and the mechanical thrombectomy, apart from the other supportive treatment which is needed in stroke.
Yes, sir.
Is that okay?
Yeah, yes, sir. Definitely.
Okay. Thank you so much, Shika. Thank you so much.
Thank you, sir.
Sharath, we can stop the.
Sir, hello.
We can stop it. We will have this in the second part next week. Okay.
Okay, sir. I will end the session, sir.
Yeah, please end the session.
Okay, sir. Thank you, sir.
Thank you, Shika.
Thank you, sir.